What is important in terms of what I'm going to talk to you and show things in the next 20 or 25 minutes or so is that how a stone center should be. I mean, stone is kind of treated badly because it happens in young people. It doesn't have the all those kudos that goes with the cancer. There's no the dread of that. And the important thing here is that it happens in people in the prime of their life, and it causes very severe pain. And then if a pilot has got even a small stone, he's not allowed to pain. I mean, he's not allowed to fly. And it's one of the most severe pain known to mankind. So let's, in the next, in my talk, I'll just cover all these things. The stones can be anywhere in the urinary tract. Most of the stones are formed in the kidney, and then they drop down to the ureter, where it gives a lot of symptoms. The stones were there in the bladder. You know that it's one of the commonest procedures that was there, as you can see, what I'll show you, is that as the countries, the socioeconomic status has improved, the stones have kind of migrated from the bladder to the kidney. And if the country is really progressing, the stones increase and increase. There were what was called stone belts that were there. In Britain, it was in 1880s or so when a lot of people had bladder stones. And as the country got better, it went up. It's very interesting. In some of the epidemiological studies say that if you got stones in the kidney, that means the country is doing well. The highest amount of stones in the world now is in Saudi Arabia. We have got the highest kind of socioeconomic strata. This is because that the stone is related to the protein consumption. When you eat more protein, when you're prosperous, when you have a lot of meat in the diet, and the protein, without our knowledge, we eat good food, and that slowly increases the stones. And that is the reason now there is a rise and the rise of stone disease. In every HES data of hospital statistics, up and down the country, the stone goes on increasing. All forms of stone treatment goes on increasing, and this is going to increase and increase. So what is new about stone surgery? In fact, lithotomy was one of the operations. There were only 3 operations known to the Romans about 5000 BC. The only 3 operations they could do. One was a circumcision because of ritualistic reasons. Number 2, the Roman army knew that if somebody was hit on the battlefield and they would become, they have loss of consciousness and lose power on the opposite side of the body, and they all had a knife just to make a hole, a burr hole on the other side, and make him walk again and start fighting or doing whatever. And thirdly, there was the bladder stone. Obviously, in those days, the diet was very poor, and bladder stones were very common and very common. And this was one of the commonest operations performed. This was in 1564, a chap is holding, and there was no anesthesia, and then you did under local anesthetic because the bladder stones were very painful, and they were willing to undergo all this. It became a very fancy operation, and Paré, who's a surgeon in France those days, was one of the chaps who kind of really made the techniques much more scientific, so to speak. But then, the surgeons and their brothers barbers, everyone started doing this surgery. And it so happened that in Paris, the mortality from this operation, which was at that time in good hands about 30 to 40%, almost 70 to 80% started dying after this operation due to sepsis. One of the commonest operations, as Ms. Jones was talking about, the various operations that were there, which were quite this was called the SHO's operation because the ureteric stones were so common, and the senior surgeons wouldn't do them, and it was the SHO who was just climbing up the ladder in urology who would do this operation. And that led to multiple battle-scarred patients. They had operations right, left, and center. He had a renal colic on the left side. He had a stone there because this disease can be bilateral. And then he went on to have a stone on the right side, another operation. And it was not uncommon in the 80s and 90s. Even the patients who have had stones in the past who have come to us now have got all these big scars in the body. Of course, the scars were not as pretty as this. They were even worse than that. So how do the patients present with stones today? Some of them are asymptomatic. I'll talk about that. And the majority of patients present with a renal colic. When the stone is in the kidney, it only gives a dull ache, which the patient is putting up with, which is a back pain or whatever, is not sure, and then it goes on. But the typical renal colic, when the stone drops into the ureter, especially if it's of a size less than 7 millimeters. Say, the smaller the stone, greater the pain, and you have this loin to groin pain, and the patient, it is an autonomic pain. Even the patient could be a big rugby player, a great hunk, but he cannot withstand this pain because this pain is autonomic. And then it is not uncommon to see these patients writhing in pain because of the colic in the A&E, however big the man is and however well-toned body he's got. So it's a very severe, nauseating pain because autonomic, a bit like what happens during delivery, same kind of thing. And if the patient has got only one kidney and that's blocked, or he's got two stones, it's not that uncommon for two stones to block the ureters at the same time. Especially this is sometimes happens when they have a long journey in the, like say from somebody's flying from Australia to here or so on, wherein because of all the pressures, the kidney stones are suddenly dropped and the patients had gone on to anuria. The stones that were quite large, like this, for instance, it has completely destroyed the kidney. It does destroy the kidney, but then it may not give any symptoms at all. Whereas the small stone is the one that gives pain. If there is one message that we take from me today, in this morning, is to see when the urine cultures, I know as GPs you do hundreds of urine cultures and treat them day in and day out, but if you see that is a urine has got proteus, then you have to think that this man or woman will have a stone somewhere in the urinary tract, and most commonly in women compared to men. And also the stone it will be large, as I showed previously. I'll show again. And it's a beautiful thing, the proteus. If you see the culture, it's almost like a coral, and that's why I put a stone in it, just so that people remember that if there is proteus in the urine, beware of stones. The other things like Klebsiella and Pseudomonas are also associated with stones, but proteus is the real thing. If you see a proteus in the urine culture, even offhand, there are hundreds of reports to look at, then something needs to be done, or at the very least, you can do an ultrasound scan of the upper tract, because almost about 8 out of 10 chance that you've got a stone there. This is a real patient of mine who's a 35-year-old lady, and she always had urinary infections, and then she was going and seeing her doctors, and she was treated with usual antibiotics, given the usual advice, it's due to sexual intercourse and you get pain, and so on. And finally, she insisted that she needed more imaging because she was an internet-savvy person. And this is a plain X-ray. And finally, when she was seen by me, she had this huge stone and this stone, and you also got gallstone for good measure. And then when you see you do a DMSA scan to see the kidney function, then her left kidney is, it is left and right reversed because that's how it's done, the scan. And there's absolutely no function. She's already lost, she's 35, the first presentation, she's got no function. And then she had to have about 8 or 9 operations. As you can see, I've cleared everything. Finally, only this much is remaining for her. And then after she got pregnant, she's a lovely child now. But all I'm trying to say is that proteus is something one has to be aware of. So coming to the classic renal colic, it's one of the most serious pain known to mankind. And it's a typical pain. The pain starts in the loin region, goes to the groin or external genitalia, or to the inner side of thigh in women, and the pain is very severe. Women who have given birth to children, they feel that the labor pain is a doddle compared to the pain. And at the end of that, there is a bit of joy there, but here's nothing until the stone comes out. And what has happened, this is just to reiterate the same point. This is a 3-dimensional reconstruction, which we do more and more for complex stones, especially to make the tract for making punctures into the kidney. This was a rugby player again. He had only a 3-millimeter stone that you can see here. And the pain was so severe, it's not uncommon that the calyx in the kidney got ruptured. And once it ruptures, the pressure goes off and the pain is completely gone. The patient, even if you don't do anything to him, he will improve because the peristalsis will kick in. This typically happens for patients who got very small stones. So how do you manage a typical case? I mean, if somebody comes to an A&E, or even if you see them in the home situation or wherever, one thing that has been worked out is that the ureteric smooth muscle responds extremely well to diclofenac or Oltrol. And if you give an Oltrol suppository, 100 milligram per PR, the pain goes off within about 15 minutes. You have to only see once to see how soon it works. And then it stays like that for 18 hours. So you got all the time to send him to an A&E or send him to another hospital so that you have that time. And the patient also feels extremely well relieved. You can give him pethidine or morphine, but the best medication is Ultrol 100 milligram PR. Of course, if he's in the A&E situation, he will have bloods taken, and the urine dipstick and microscopy may not happen as an urgent thing, but the urine dipstick will be positive for blood in 98.3% sensitivity. So almost everybody in the situation of a severe pain, you don't have many investigations immediately when you see them to find out, but just a urine dipstick, if he has got hematuria in the background of a pain that is so severe, then almost your diagnosis is there. The investigations, the non-contrast IVU and all that have gone out of fashion now. You only do a non-contrast CT KUB. It's a low-dose CT, and it only takes about 10 minutes at the most in the A&E or in the radiology. And other thing that has come up recently is to give them an alpha blocker. If you give them tamsulosin, I'm sure you're all familiar with usage in the prostate setting for the lower urinary tract symptoms of older men. But then the same medication will, both in men and women, works. The alpha blockers will immediately act because it relaxes the same receptors are there in the lower ureter. It relaxes the lower ureter. Thereby, one, the pain requirement becomes less, and number two, it'll also help to passage of stone. So another thing you can do is to give them an alpha blocker. You can't be wrong. Just ask them to take Flomax or Flomax or tamsulosin in the dosage of 400 milligram once a day, and that will facilitate the passage of stones. And then you can have time to refer them to the stone clinic. So as I mentioned, non-contrast CT, this is only is very low CT, but you can beautifully see the stone. And not only that, the non-contrast CT will also pick up any other abnormality, for instance, an older patient where you may have other things going on, whether they have got an aneurysm, always a worry when an elderly patient comes with the pain. So it will also pick up other things, although you're not given any contrast. And thirdly, about 10 to 15%, now it's become nearly 20% of patients have got uric acid stones with obesity. I'll talk in a minute. And these patients, which are not commonly seen because they're radiolucent in an ordinary X-ray, can also be seen in the CT KUB. So it's got a lot of advantages, and it can be done very quickly, and the radiologists don't like giving a contrast, waiting 20 minutes film and so on for IVU, and this happens without any problem. You don't even need a radiologist to do it, and the radiographer will do that, and you can see the pictures from home and side. This is a patient who has already lost his kidney with this fairly large stone, which was kind of asymptomatic for a while. And the stones can be anywhere. This is in the upper calyx, just for example. And what we are doing again, I kind of showed you a three-dimensional picture. This patient was sent to me from London. This lady was almost considered that she's onto drugs, and that's why she goes on to one hospital to another with pain. And then when you investigate, the issue here is that she's got two moieties on the left side. She's got two kidneys on the left side. And if you do the ordinary scan, you don't see anything, and they can see that the parenchyma, as the upper part of the upper moiety, is all gone. And what you're seeing like a stone is in fact is a calyceal system in the 3D reconstruction. But the real clinch is in here, where she has got the upper ureter, and in the middle of upper ureter, she has got a dark area, which I've enlarged it here. And this is a stone which is blocking the upper moiety. And you won't believe, the moment I went in with the telescope and this stone was cleared, she's pain-free, she's not visiting any other A&E, she's not troubling her GP, and she's a lovely 28-year-old girl. She's gone back to her business, and now she's doing nursing, in fact. So what is important here to say is that in this kind of difficult situation, you need a 3D reconstruction, and it is quite easy because most of the radiologists have this software, and then only you need what you're asking for, and then you can see. Suppose you see a small stone, how long can you wait? So it's made very easy. This is kind of my own formula. Multiply that by a formula, by 4. So if there is somebody has got a 2 millimeter stone, 2 into 4, 8 days, you can give the Ultrol and the tamsulosin, and there's a good chance it passes. But if the patient has got a stone more than 7 millimeters, it is unlikely to pass because the diameter of the ureter is 5 millimeters, and although it can go up to 6, it's unlikely it goes more than that. And roughly, you got about 3 weeks window, however stone that's there, you can pass. So you can definitely, if somebody has not passed a stone in 3 weeks, it's unlikely the person will pass the stone. What you have to be aware of here when you are seeing a patient of this nature, all that I have said so far is valid, but the most important thing, however, is not to forget that a kidney can be blocked and the patient can get septic. If somebody has got an acute loin pain and is looking really unwell, and then in that situation, the stone is really blocking. And once the combination of an obstruction followed by infection, which increases the intrapelvic pressure, is a very bad thing, because the intrapelvic pressure has got lots of communication with the lymphatics and the blood supply. And if the endotoxin build up within the renal pelvis and there's an obstruction and infection, it raises the pressure, and thereby the endotoxins go into the system, and then they become very poorly very soon, requiring ITU, or they may die. This is a typical situation when somebody's catheter is changed in a nursing home. So nothing has happened, the patient is fine, all they've done is the district nurses come and change the catheter. But all what has happened is a bit of debris, bit of infection, the patient is very unwell, and if he is not treated in time, then the older patient may die. So obstruction, infection is a real emergency, and then they have to be immediately sent to an A&E or the hospital, where they can either have a nephrostomy tube or you put in a stent in, and both of them are valid as soon as the time is of the quintessence, and once you put in and unblock the kidney, they are fine. In fact, even patients who are extremely ill, the ITU likes these patients, because once they've been given fluids, they've been given a bit of NORAD, and then you unblock the kidney, they do extremely well, and it's good for their figures as well. The patient is only there for 2 days and is gone happily from the ITU. So how do you manage stones? Very small stones in the kidney which are not causing any trouble, patient has got no symptom, then they can be left alone. But most of the symptomatic stones require treatment. So we've got 3 modes of treatment. Either you can break the stone in situ, the lithotripsy, which has been there from the 1980s, or you can pass in very fine telescopes into the urinary tract and then using laser break the stones. I will talk about that. Or for larger stones, you make a hole in the kidney and break them with a different type of energy, and large chunks of stones are taken out, and the patient is made stone-free, as is showed, like the lady I showed the example of. This is the lithotripsy we have in Dartford, and we are one of the few hospitals in the country to have our own lithotripter, which is about £250,000, which will work. And then we got the same partnership with Falcom, so we can use them as a shared care situation. The second thing is to have a look into the stones with the telescope. And this is the Endourology theatre in Dartford, but the theatre in Falcom is also similar, where you've got a C-arm, you've got the screen to see in everything in high definition, you've got the X-rays, you've got the laser machine. So you require all this setup, and I'm now trying to get a £500,000 specialist table in Dartford, which is kind of all singing and all dancing. And what it'll also do is this X-ray is built in the table, so you don't have to take the radiographer's time, and you can do day or night whenever you want without having any hassle. And here you can see that this is the various telescopes. I will go into it. And the telescopes have advanced. The one thing that has really improved is not so much the surgeon or his skill, but the gadgets that have come in. You got the extremely fine instruments. This is only about 3 millimeters at the tip. And if you go in and it opens up, it has got 2 channels apart from the vision channel under, you got a digital chip to see what you're doing, and then you've got the laser fiber going beautifully, and then you also has got a basket to entrap it in the kidney from outside the body, sitting about 3 feet from the patient. So this kind of technology is what really has made the stone surgery so much more very perfect And also you got the laser fiber, which is going up to 150 micron. You can't even see sometimes, the fiber is so thin, where you can reach the areas in the kidney which you could never reach from outside the body and laser them. So this is just an example of a patient who has got a large stone in the renal pelvis, and you can have the beautiful views, and you can see how it's going. This is more than 1.5 centimeter stone, and you can see that the laser fiber is coming in, and then it is breaking the stone, and within about 5 minutes or 3 minutes of lasering, the stone is completely broken. Some stones are hard, some stones are short, are not so hard, but any stone that has got, which looks like a beautiful coral, is a good one to break in. But if it is a round stone, then usually it takes more time to break. This is yet another example, wherein here, the stone is in the ureter. I didn't want it to go anywhere else, so I put it in a basket so that it's completely held in a cage so that it doesn't move anywhere, and very easily, as you can see, the stone gets broken and the whole thing is cleared after that. So I mentioned to you that any part of the kidney can be reached with the various telescopes, and then you got either a bendy or a rigid telescope, and they could be lasered. And here you got a large stone in the renal pelvis, which has been also treated. So just to say that, as Falcom Manor Hospital is like the private hospital for Dartford area, and it's for all areas really, is that we have got the same kind of equipment that what we got in the NHS in the private sector. And I think Falcom, and thanks to Valerie, is one of the hospitals in the region which had the laser first bought. This is about 4 or 5 years ago. And all these gadgets, what I do in the NHS, I could mirror them also in the private setup. So the setup is there in Falcom. And next, coming on to the PCNL, which is a keyhole surgery. This is my setup in Dartford again. And then just the patient with a large stone, and everything is draped up. And you can see that this is the big stone here, what we're talking about. And then I've put in a special balloon to make the kidney blow up a bit so that I can see it properly. We use both ultrasound as well as the X-ray, and we do our own tracks. And you can see the needle going into the kidney, and the whole thing is stretched. Then the whole thing is cleared now, and then you got a nephrostomy tube which comes out the next day. So what is a stone center? It's not just having a laser, or it's just having few equipments or 1 or 2 surgeons and saying that we have a stone center. We have well and truly established stone center in Dartford, which is comparable, which I'm very proud to say, comparable to any best center in the country or even internationally. So much so, I was asked by our society, the BAVS and the NHS England, to go and set up a stone centre in Wales, in the north of Wales. They gave me £1 million saying, what all you need for a stone centre, and can you please help? And you can see here, first of all, you should have a tertiary referral centre. You need to be having patients sent from everywhere to have the mass, and then you need to have the stone MDT. We talk about cancer MDT, but again, these are complex stones, and this also requires discussion with the radiologist, with the, you saw all the 3-dimensional pictures, and then you also need a nephrology help as well as your colleague surgeons. So why it is that we are having the stones? In the numbers that is coming, I told about the socioeconomic progress. And there is what's called the stone belt, which goes from country to country. Ethiopia and Somalia, which we consider the poor countries, had its stone belt just in 2002. So they had a stone wave. So the stones, which was very common in bladder, went all up to kidney. For India and Pakistan, it came in the 1960s. Another curious point is that whenever there has been a downturn in the economics, the epidemiologists have seen that the stone incidence comes down. At the First World War, although I mentioned that Britain had it in the 1880s, the stone belt and the stone wave, in the First World War, again, there was a dip in the stone incidence. Second World War, there's a dip in the stone incidence. And let's forget all that. We know we had this internet and the dot-com crisis of the 2000s. Even then, there was a dip in the number of stone patients. So it is kind of, it mirrors what happens to the economics of an individual country. But then, all that is true for calcium oxalate stones. But now, we are in another epidemic of the uric acid stones, which happens because of the globicity. It's a worldwide problem. We are all eating more, we are all getting fatter, and then as a part of that, one will develop a metabolic syndrome, and then the metabolic syndrome is related to stone formation. We all know about metabolic syndrome, and as primary care physicians, you know better than me, many times better than me, that what all this implies. You got this obesity, you got high blood pressure, triglycerides, cholesterol, and then diabetes associated with it. And then we also know about the various cardiovascular implications and stroke and so on. But what also is there in this group is they also form stones. They form very large uric acid stones. And they have a high prevalence of kidney stones. The severe expression of disease, they almost become a malignant stone formers, and they have uric acid stones which are not seen by ordinary X-ray, but of course seen by the CT. We did our own study of these patients, about 300 or so patients, and the morbidly obese patients whose BMI is more than 35, but a mean of 40, they all had high incidence of stones. They all had metabolic syndrome, hyperlipidemia, and one of the main areas where we're researching now is to how to prevent this metabolic stone disease because it's a relatively new thing in the world. And what happens in the metabolic syndrome is that they develop insulin resistance, and because of insulin resistance, the urine becomes very acidic, and the precipitation of uric acid crystals, hyperuricosuriia, and this is the acid urine. If you just take any diabetic who is on insulin, for instance, or a diabetic who has been on metformin or so for 10, 12 years, his urine is acidic compared to a normal population. And this uric acid, which is an acid, it crystallizes in an acid urine, and then they form stones. So what else is coming? What else is new other than the technology and what I've spoken to so far? Is a new thing that has come up. It's called the Oxalobacter formigenes. It's called Oxalobacter formigenes because it breaks the oxalates in the bowel. So this has come out as a big kind of panacea now to treat patients. It's not still fully licensed, but it's coming. What is Oxalobacter? It is an anaerobic bacterium, like there are so many anaerobic bacteria in the colon, and it's not there for every person. So it's only between about, say, 40 to 70% of people have it. The other thing about this Oxalobacter formigenes is that it eats oxalate, so it destroys oxalate. Its whole source of energy is oxalate, and it's antibiotic sensitive. So another thing that might happen is if you treat with antibiotics when it's not necessary, we might also lose Oxalobacter amongst various other things we lose. And this leads to less stone formation. This is a complex diagram what happens, but ultimately what it does is it takes the oxalate substrate so that there is not enough oxalates to form stones. The Oxalobacter will decrease calcium oxalate. This has been tried in children who have got primary oxalosis. Primary oxalosis is a very serious condition. Children kind of die within 3 or 4 years. They have to have liver transplant and kidney transplant. And even after that, oxalosis is genetic. It comes back to them. It's a very difficult condition. And there has been studies to give this Oxalobacter, and then it's coming down. The whole thing came up with this study from a chap called Alan Rogers from South Africa. We know that in South Africa there are the black population and the white population. They almost live very closely, and then they eat the same kind of food, so to speak. But why do the black people have got an immunity on stone formation? In fact, black people as a race, they are less prone for stone formation. And the typical example is Sudan, where the temperatures are so high. And in the middle of Sudan, you know that recently the southern Sudan got independence. So you've got northern Sudan and southern Sudan. The northern Sudan have got the Arabs, who are an Asian race, and the southern Sudan have got the black race. And as if you're drawing a line in the middle, and in fact, your equator goes in the middle as well. So it divides into northern, southern Sudan. The southern Sudan, the black population have got no stones at all, although they are in the same country, eating the same kind of food, whereas the Arabs have got high stones. So the Caucasians, as well as the Asians, are more prone for stone formation, but not the black race. But that's the reason this Oxalobacter came up. That was the main basis to find Oxalobacter. So Alan Rogers, what he did was that he found out that the black population have got a very high amount of Oxalobacter compared to the white population. And if you see more studies, the amount of oxalate utilized over 5 days, it is a very complex operation, complex study where the study subjects had to give the stool sample almost on a daily basis, and it's based on the gram of tissue. So the black population has got more of oxalate utilization than the white. So what is the kind of translational point from all this? From translational point of all this, we know that we've got Yakult, we've got various kind of bio-yogurts and probiotics which we give. And I think Oxthia, which is the trademark of this, it doesn't have enough scientific basis at the moment to give for general consumption, but this is one area where lots of things are being done, and hopefully in the next 4 or 5 years, we do have an oxalobacter type drink that we can have, or in whatever form, to decrease the stone formation. So what happens to the bariatric surgery and stones? This is another area where we're all getting obese, we're having various gastric bypasses done, laparoscopic or otherwise. But then when the patient has got the obesity, which we talked about, they form uric acid stones. But once they've had this gastric banding, within about 2 or 3 years, like this lady had, she formed a stone on the other side. And this is because of the calcium oxalate stones, because the bowel is a short gut. In other words, there's no win over the stones. Whatever you do, it's not right. So what can you do, though, to prevent the stones with the existing knowledge we have? There are a number of parameters which we mentioned, the diet, etc., which will increase the stone. All good things form stones. Red wine forms stones, red meat forms stones, cheese. So you can't become a saint and go and sit on Himalayas and then do some pilgrimage. So we have to live. So what I advise patients is live in moderation, have everything. But there are 2 things which inhibit stone in the body. We're called the natural inhibitors. One is the magnesium, and second is citrate. Obviously, we can't take magnesium in the form of diet, which is a heavy metal, and there's diarrhea and other problems. But what is important is, if you have citrates, because if you see the female, when they are in the reproductive period, they have got slightly less incidence of stone formation in the ratio of 3:1. If every 3 men of a particular age between 20 and 40 gets a stone, only 1 woman gets a stone. But then that changes in the postmenopausal period. This is largely attributed to the estrogen and the citrates. The citrate is a natural inhibitor of stone. So it makes the urine more alkaline. It also makes it kind of blocks the pathway, so that more calcium is excreted, and citrate is a real friend. So and then they did a big study in California. It's not like the grandmother's medication. In California, 2,000 people were randomized between having all sorts of dietary restriction or do nothing but have a lemon a day. A lemon a day, a fruit, gives you 30 milligrams of citrate, and that's what we need to balance this. So I tell all my patients, whatever we do the metabolic study and so on, and give you a bespoke diet, till then, a lemon a day keeps stones away. So in conclusion, stone disease is ever increasing. With fine caliber telescopes, we said that how nicely we can reach all the things. And the most important thing is to prevent this problem. Think of lemon for prevention. Oxalobacter may hold the key for the future, and beware of metabolic syndrome. Thank you.